Hi, I'm Ron Mitchell, editor and publisher of the Bay State Banner, and I'm here with GBH Amplifies at the Boston Public Library Newsfeed Cafe. We just had a great conversation about public health and supporting our public health care system here in Massachusetts. We had three amazing guests who have spent their whole careers doing everything they could to help support our state and city's public health care systems. I hope you'll listen in. It's coming up next. Hi, everybody, and welcome to another episode of GBH Amplifies. I'm Rod Mitchell, the publisher, editor-in-chief of the Bay State Banner newspaper, New England's black-owned newspaper that serves our black, brown, and progressive communities. And I'm glad to be here with three incredible guest panelists who have made a profound impact on New England's healthcare system. Each of our guests has spent their lives helping to create, support, and advance the public healthcare system here in our state. Our first guest on the far side is Michael Curry, President and CEO of Mass League of Community Health Centers and member of the NAACP National Board of Directors. Next to him is Nashira Baril, Director of Neighborhood Birth Center and formerly with the City of Boston's Health Commission. And to my immediate is Dr. Charles Anderson, President and CEO of the Dimock Center. I want to thank all of you for being here.
Thank you.
Thank you, Rob.
So today we're here to talk obviously about healthcare. And as the Trump administration in Washington takes aim on the national healthcare system and moves to slash federal funding, where do you folks see the power, resilience, and determination within our community to create lasting support for our healthcare system? I'll start with you, Mike.
Yeah, I mean, one is I think there's a lot of proposals coming out of this administration that terrify many of us who work in healthcare, work around health policy. What gives me some hope is that the proposals being put forth impact most Americans in a negative way. So even if you did vote for a particular party or particular candidate, when your rural hospital closes, it's going to matter to you. When you can't afford your medicine for whatever condition you have, it's going to matter to you. When you don't have access to a community health center or another pharmacy in your community, it's going to matter to you. When you can't afford the copay, the cost co-insurance, it's going to matter to you. So I think what we're going to have to do is wait for the ripple effects of some of these policy decisions to penetrate and impact most Americans, and then they'll make different decisions.
Definitely. Nashira?
I feel hopeful in the way that community is organizing and showing up. We've always been the ones to provide care for ourselves and to resist and to heal. And so I am really turning local these days and feeling a lot of resolve in the ways that people are coming together. And there's no denial that the threats are really significant. And I think that we'll be the ones to get ourselves free.
Wonderful. Dr. Anderson?
You know, I'd actually second that as well. I mean, I think there's a tremendous amount of inherent resilience in our communities, and especially where I sit at the Dimock Center, we're talking about a historic institution that's been there for over 160 years and has weathered so many storms during that period of time, world wars, you name it. Kind of think about what this institution's been through and supporting community through all of that. We're the same institution. We have the same mission. It was always about for us, by us, and that's what we're here to do today. And I think that gives me hope because we've seen that work in the past and it will work now.
Wonderful. As the administration does what most people feel are indiscriminate cuts, making large sweeping slashes without, determining where those effects are going to fall. Nashira, talk to us a little bit about the birthing center that you're working on and how you feel that might help some of the maternal disparities going on in our society and in our community.
Yeah, thank you. We've seen persistent inequities for many years, and in particular in maternal and child health. So I think the threats to the administration certainly can exacerbate those. And again, the answer has always been in community health, as Dr. Anderson said. And so we're working to open Neighborhood Birth Center, which will be the city's first community birth center, and to really reintegrate midwifery in the community. And birth centers around the country are an evidence-based strategy to improve maternal health, infant outcomes and experiences, and public health more broadly. And so again, really rooting the response and the answer in community. The Neighborhood Birth Center is a decades-old vision, so it's not in response to the current administration, but it is directly in response to years of persistent inequity and trauma. And so really this is a trauma-informed mode of healing and bringing care back into community.
So trying to address the inequities from the bottom up and provide community-based solutions, right on the ground with the folks that need that support.
That's right. The majority of people who are pregnant can give birth safely outside of the hospital with the support of highly trained, licensed midwives. And so this really is an effort to to normalize physiologic birth, natural childbirth. And for those who do need the support of hospital, we'll also, provide GYN care and safe transfers, as well as a number of community programs for parents and families. So it really is about getting care back in the community and being circled and surrounded in love.
Got it. Now, I know you had a minor setback in the zoning request for your location, but I understand there is some movement on some other options and some other possibilities?
This, as I said, this is a decades-long vision, and so while the zoning board did not vote in our favor last week for us to build on the parcel that we have purchased, we're really hopeful that there will be a birth center in Boston, and my hope is that it's in Roxbury.
Wonderful. Switching gears now a little bit, Mike, I want to come out to you and talk about the indiscriminate cuts that the administration has taken, and have you seen an actual effect within the systems that you guys oversee within the healthcare hospitals? Have you seen an actual cut in funding?
Yeah, well, I want to clarify. So I think it's proposed cuts, and it's cuts out of the administration and cuts out of Congress. Right? Because really the budget process will really happen out of Congress.
I guess my question is, and I get it, the money is determined and allocated through Congress,
Yeah.
but it seems that Trump has bypassed that process and cut staffing. So maybe my question shouldn't be, the question is, have you seen funding reductions? Not yet is your answer, obviously.
Yeah.
But have you seen reductions in support because of the indiscriminate employment cuts?
Yeah,
that's
I'm going to get to that. So I think there's a few things. So one is when you cut staff and federal staff, which he's done sweeping cuts to people, not programs, but sweeping cuts to people, you've diminished the capacity for those agencies to respond to the needs of those grantees. Health centers are one of those grantees. So whether it's NIH or whether it's CDC or whether it's HRSA, all those agencies rely on federal staff to be responsive, to make sure that programs are running appropriately, that they have the resources they need. So that's one. There's going to be a ripple effect and an impact of all those federal cuts to staff. When you think about money, we haven't gotten there yet, but there are proposals. There is, I think, $880 billion that they want to achieve in savings. It's almost unforeseeable that you could do that without cutting Medicaid. So they're saying, we're not going to cut Medicaid.
But we're going to cut everything else.
But well, no, they're saying not going to cut Medicaid, but it's unlikely that you can make that degree of cuts without touching Medicaid. So what they're saying is, we're going to go after fraud, waste, and abuse. Ultimately, that might mean a conflation of what fraud is from a strict legal definition to you shouldn't be on Medicaid. We don't think as an adult you should be on Medicaid. That's not fraud. That is a state-by-state choice on their Medicaid populations, and of course with federal funding. To me, that's the challenge of our time, is whether we then find ourselves trying to defend our programs, the adult Medicaid population that but for that coverage would not get care. They would not come in to primary care. They would be delayed in getting their cancer diagnosed or their diabetes managed. To me, that's the biggest concern. So the cuts are likely to come, but they're likely to come out of Congress at the direction of this president.
And we saw the PR rollout during his speech recently, his State of the Union speech, where he listed, and it was fact-checked, a whole bunch of fictional stats about illegal, false people on the rolls, claiming there were people over 100, over 200 years old, and thousands of them, or tens of thousands of them in many cases, over that age group. And that was fact-checked by many media outlets saying that all that was totally false. That's the PR. It seems that might be the PR, justification rolling out.
I mean, ultimately, part of the whole issue about community is we got to turn out and advocate and tell the truth, right? Isolated examples doesn't mean the rule. Most people who are on Medicaid, many of which are not Black and brown, rely on Medicaid for services. They have access to primary care or to insurance, which then gives them access to care, which ultimately saves us in the long run. And Dr. Anderson's heard me say this now: pay greater or pay greater, pay now or pay greater later. That I'd rather you have insurance, go to a primary care provider, get your immunizations, get your primary care, your preventive care, than see you in an emergency room where it costs more money. And quite frankly, you're going to be closer to not being able to manage that acute condition that we could have treated earlier. So that's really what we're talking about. And I do have concerns that this Congress needs to hear that message and make the policy that does not cut Medicaid.
Got it. Dr. Anderson, have you seen challenges to servicing your community because of the staffing cuts coming from Washington, or are you not as directly?
I think the big things that we're seeing is anytime there's this sort of threat, it impacts everybody who's trying to provide the care, right? The sense of fear, the sense of uncertainty. You know, I spend a large part of my day really reassuring people that A, the way tyranny works is you have to have fear on the other side. So let's not be fearful, A. B, let's not let anything steal our joy because we still have to show up, we have to smile, and we have to engage with those that we're serving. We don't want to lose the ability to do that. And third, we have to make sure we stay focused on our mission and realizing that we're the solution to so much of this. I think one thing that's a real common thread here is that there is a vital role for community in this process, which was defined back even in the mid-60s, right? When this whole movement started, it was really clear why 51% of my board are members of the community who receive services. I don't think everyone really understands the criticality of that, because what that means is every decision that I make, I have to answer to the community to make sure that that's going to meet the community's needs. Doesn't that just make so much sense?
Well, it does. You have to work with the community that you serve.
You do, but I've got to make sure I've got a staff of 500 people. And remember, we do healthcare. Also at the Dimock Center, we have a Head Start program. So similar sort of things there, similar movement, war on poverty. How do we change the trajectory for communities? And that's what we're here to do. So the reality is that in terms of the impact, these threats make people really concerned about, can we do this, right? Are we going to have the funding to continue this work? Is my job secure? Those are the things that we're facing.
What community partners do you have that help you provide those services? I know you were talking about your staffing, but specifically, what are some of the programs? And just to share with us some of the.
Sure. Well, we have a full range of community partners. And of course, you start going down that list, you leave somebody out.
Okay,
I want to be careful there, but think about it this way. Our biggest community partner are those who receive services and that we listen to every day, and to make sure that we're meeting the needs. Outside of that, I should state, we have a range of partners, which also gives me hope. We're in a state where we have people who really understand the value of this. There are corporations, there are foundations who really, really understand the criticality of this. I will mention one because I happen to be on the board of that, which is the Boston Foundation. So hopefully I won't get in trouble that I'm leaving some others out. But the reality is that here's an organization that is really, really critical to making sure that resources, not only resources are available, but that we have the opportunity to convene and to organize in ways that brings different stakeholders together to say, here's the way we can understand these problems, and here's how we can solve them together, centering it around community. That's the range of, when you talk about the support and community partners, that's really a part of what this is. And of course, our financial partners, I don't want to leave that out. There's some who are just amazing, and they're there every time we run into challenges. And more importantly, as we start to think about the new things that we need to be embarking on to better meet the needs.
And Nashira, as you move forward with the Birth Center to help address some of these inequities in maternal health, so who are some of your community partners that you've been working with to get that goal, to get over that goal, to open you?
These two and their organizations. And I was really resonating with what you said about Boston Foundation and philanthropic partners. You know, healthcare costs should be borne by the insurance industry largely. And in this moment also, I'm feeling really surrounded and supported by the philanthropic community. The Birth Center is not open yet, and so for many years of planning, we've been supported philanthropically. And right now, midwifery care is undervalued in the insurance industry, and so there is a gap that we have to make up. And while we advocate for better contracts, we also are again supported philanthropically. And so, one, I think the philanthropic partners, we have an incredible partnership with Boston Medical Center. That's the hospital that we will transfer to in case of an emergency. And they've just been incredible, funding partners, thought partners, and community leaders in particular in midwifery. And I think also, there is a really robust birth justice ecosystem here in the Commonwealth and in Boston. And so we've got folks who are working on, lactation support, home birth access, doula access. So it's a really robust ecosystem, and we've got incredible partners.
Talk to us really quickly, and I want to give you a chance to talk about the history of midwifery in the Black and brown community. I know that, looking back over the past couple hundred years, the Black nanny, was responsible for majority of those responsibilities for hundreds of years in our community, and then even prior to that in our, Afrocentric and the African diaspora. So let me give you just a minute to talk about that.
Just a minute, okay.
Just a minute. It's a long conversation.
It is. I'll come back. Yeah, absolutely. I mean, midwives globally have been catching all the babies since the beginning of time. And in the Black community in particular, the grand midwives of this country and the indigenous midwives caught their babies as well as, all of the community's babies. And there was a real marked effort to criminalize midwifery in the late 1800s and to really move care into the hospital system as we know it now and into modern obstetrics. And there were efforts that were supported and led by state health departments to slander midwives as filthy and as unsafe, and to really make the practice of midwifery illegal. And so I think we're still paying the price of that now. The midwives have always been here, and there is now a resurgence, I think, of midwives and community midwives. But I think we're still paying the price for that divestment and really the way that our system has advantaged hospital-based obstetrics at a real cost to outcomes and experiences and cost to the healthcare system. It's much more expensive to have your pregnancy and UN care and OB care in the hospital than it is in a community setting. And so.
But you do, as you said, partner with BMC, Boston Medical Center, to take care of any particular patient that might have complications that.
Absolutely. Yeah. I mean, I think, we're designing this with safety at the center. So we always want to make sure that we have, transfer protocols and guidelines, not only to BMC, but to other area hospitals that we're building really great partnerships with. And we are in a healthcare metropolis here. And so, you can turn around and hit a community health center and a hospital. And so we really want Neighborhood Birth Center to be integrated into that system and to be partners with the community health centers and hospitals so we can be making referrals and we can send the newborn and the parent to primary care and pediatrics back at the community health centers and to make those high-risk referrals as needed. And also to be a place where people, even if they are not birthing, getting their care at the birth center, can come for a dad's group or a queer parents group or a group about miscarriage and loss, right? So we really want to be a hub where people can gather.
To provide multiple levels of support for this particular community. That's wonderful. And I like the phrase you said, healthcare metropolis. And I want to talk about that a little bit. Mike, I want to come over to you. Recently in our Massachusetts healthcare metropolis, we've had a little bit of turmoil with the Steward healthcare system collapse. And I want to ask you a few questions about that. And can you share with us about the closing of Steward Healthcare and how it has affected many of the community healthcare centers around our state?
Yeah. So one is, I think we're at a critical point in how we address policy in Massachusetts. And I think we've been trying to address this for years. And the debacle that we'll call Steward Healthcare as a system forced us to have to think about it, right? We let for-profit venture capital-backed entities into Massachusetts, and they took over a network of hospitals. It is clear that it was not in the best interest of patients, that quite frankly, they didn't invest in those hospitals. They let them deteriorate. Arguably, the quality of care in some were not what it should have been. And then all of a sudden, they found themselves in a financial conditions that they sold off the buildings. So the value of those systems were now drained out. And those who were at the top, many of those names we know now, took that profit and that wealth and walked away. And then now we're left as a state trying to pick up the pieces and figure out how do we make sure people still get care, that they get timely care. And in Dorchester, being Kearney Hospital, where that was located, is now absent a hospital. So I co-chair the working group that the governor appointed me to, as well as Mayor Wu, with Dr. Ojukutu from the Boston Public Health Commission. We spent the last 4-5 months meeting with experts, meeting with community to figure out what comes next with that community. But it's a broader conversation around what do we value, how do we prioritize and center patient, and make sure that no matter who comes in, that they're accountable for their financial status, that they're investing in their facilities, they're providing quality care. The legislature's taken this up. I think the first iteration of their policies to address this has just recently passed. We have to make sure going forward that we never experience that again. Health centers are too important to fail. Hospitals are too important to fail, and we can put the structures and the requirements in place to make sure that doesn't happen again. So health centers are seeing the overflow of those patients who are no longer able to get to Kearney, who are now walking our doors, and wait times are already long to get in to see a health center provider. This exacerbates that for us.
Yeah, Dr. Anderson, I wanted to reach out. I wanted to turn to you and ask you, after the Stewart Health System collapse, did you guys see a very large influx of primary care patients, folks trying to get appointments, trying to identify more healthcare opportunities?
Absolutely. I mean, I think what we've found though as well is, and this is what Dr. Curry mentioned. I always like to call him Dr. Curry. What he mentioned as well is that we were already at a place where we had wait list. We were already at a place where
was
the system already
was already heavily taxed.
So part of what we had happen was now you had an increase in just that burden on the system that was already struggling with just trying to get a lot of our existing patients in. So what we're really finding is that the wait lists have got that much longer, really decreasing access to these sorts of services, more strain on the system, allowing us to start to think about different ways of doing this, but to try to do that and this reimagining what care needs to look like in that classic way of putting the wings on the plane while it's flying, which is a real challenge. So we're having to redesign how we do things because of this increased demand for our services.
And Ron, just before we jump off that, so I always tell people the crisis existed before COVID, the crisis existed before the Stewart closures, the crisis existed before these recent federal policies. We already had people stuck in the wrong places to get care, right? Unable to get a bed in a hospital. We already had the cost of care going up, so people couldn't afford the care that they get. We had pharmacy deserts. We know in Roxbury, the closure of pharmacies.
Yep.
There was a myriad of issues that we were having. The finances of health centers, we weren't being reimbursed appropriately to provide the care. Hospitals have the same challenge. There's a crisis in our system. The model's not working. And then when you add on a circumstance like a hospital closure or a pandemic or now bad federal policy, you could wipe out the network as we know it today.
So as we look forward in this coming year, I want to ask each of you, what are your biggest concerns? And I know we talked about the potential funding, but specifically, what are the biggest concerns in your constituents that you're most concerned about? And since you finished, Mike, we'll start with you. Actually, Nashira, just to keep the rotation going.
The biggest concern we see?
Yeah, the biggest concern with the potential funding cuts to Medicaid and what the Project 2025 template, even though the Republicans ran from it during the election, it's clear that that's the template they're using now. So in anticipation of what Congress might do, what are your biggest concerns for the folks that you serve?
Yeah, I mean, I think as Michael said, it wasn't great before, but I think we can expect inequities to exacerbate over time across measures, health outcomes, but also inequity in income, education. We know that there are threats to all of those systems and the ways that all of the systems interact. And so I think we can expect to see outcomes and experiences worsen. And I think that, as Dr. Anderson said, the threats, right? The fear also gets in the body. And I think that there's a real concern for a lot of people just living in this moment, whether it's the threats of deportation or of losing their health care, that there are real physiologic threats. I'm not the physician on the panel, so I'll turn to you, but there are real physiologic threats as well. And so I think that we can expect to see, outcomes and experiences worsen over time. And again, I think how we come together and respond as community is important. Unfortunately, I think that the outcomes, the impacts of this administration are not 4 years. They will be felt for many, many years past that.
Mm-hmm. Dr. Anderson, I want to ask you to kind of follow up on this question. Obviously, a majority of the community you serve are aging. And in our state, we have a very large aging population. So cuts to Medicare, Medicaid, which helps to fund a lot of low-income folks' health care, must be extremely concerning to you. So share with us some of your concerns about your most vulnerable clientele, the senior, one of your most vulnerable.
Sure. I think, if we look specifically when we think about Medicaid, sometimes people get confused and think Medicaid is just about young people, poor people. Medicaid also is what is supporting grandma very often in the nursing home. So part of this is going to be, guess who's coming back home? And are we prepared for that? So the reality is we've got this vulnerable population. Let's talk about the elderly and access to services. That's a population that we know the range of what we need to do goes far beyond stethoscopes and antibiotics, right? So
And that population is growing.
and that population is
percentage-wise.
growing. But let's also remember, again, we have vulnerable populations across all of what we do. So we've got to think about the vulnerabilities of the elderly. We have to think about the vulnerabilities of the children. We have to think about the vulnerabilities of our staff. I think one of the things that's really important, and I don't think people completely understand, when we talk about places like the Dimock Center, we're the largest employer in Roxbury. So in 02119, we are actually part of the economic engine for that community. We're making sure that people have access to health insurance because as an employer, we're able to do that. We are actually one of the few places where people know that they can drop their child off when they're 1 and 2 years old and they're getting child care in this Head Start environment that's supporting those social emotional needs of the child while at the same time supporting that family. These are all points of vulnerability in our minds. And we know that we have to look at this holistically, and that's what's critical. We also have 1/3 of the detox beds on our campus. So that's another area of vulnerability. So how do we make sure that we stabilize all of these various components at the same time? So to your point, yes, we have individual pockets of vulnerability, but where we sit, we have to make sure that we're looking at the entirety of the individual, the entirety of the family, and the entirety of the community. But what I will offer is that that is what we've been doing well before this administration, well before the pandemic. Has it been challenged? Absolutely. There's no doubt about it. And I think if anything, this allows us to shine an even brighter light on where the opportunities are to work together to address those fundamental challenges. Because this is a system that for the city of Boston, almost every other person in the city of Boston gets their care at one of the 22 community health centers.
Yeah, that is a
Think
tremendous stat.
about, if you really, really think about that, that
You
tells
say
you
one
that,
of every two.
every other person
Every other person, one
in the
every
city
two.
of Boston, if you really start to narrow down who are in that 1 and 2, right?
Yeah, yeah.
You really realize this is a critical part of the healthcare system. And understanding that if we lose any components of that, how does that care get provided? And one other really important point when we think about all of what we do centered around community, it's one thing to make services affordable. It's another thing to make them accessible. But how do you make sure they're approachable? And I can tell you, when I have someone come in and at the front desk they see their neighbor's nephew or niece, that gives them the sense of this is a place that I'm going to be seen, I'm going to be heard, and I'm going to get the type of care that I can engage in to get to the type of outcomes that I know I want for myself and my family.
Well, thank you so much, Dr. Anderson. I want to give each of you guys just a little bit
Can I answer that
opportunity
question
to
about challenges?
share the good news of what's going on.
Can I answer that question about challenges? Because I wanted to add to that conversation. So one is, after George Floyd's murder and COVID, there was an epiphany, awakening for some. We knew it already, that we needed to address health disparities, that Black women are less likely to survive breast cancer, that Black women are more likely to have an adverse outcome, pregnancy, colon cancer, prostate, sickle cell, go down the list. Almost every disease I can name, 2-3 times more likely COVID. What I'm concerned about is we're now going to withdraw from all that progress we made. We're now systems, institutions, we're prioritizing health equity, investing in interventions, outreach, community health workers, programs, specific programs. There's an object of this administration that I'm concerned about going after health equity programs like DEI, like stroke programs for Black men or Latino men. We have to be vigilant on that. The other thing from a community health center perspective is the strain of our entire healthcare system financially. Dr. Anderson mentioned it, 22 health centers in Boston, 50 in the state, 1 in 7 people in the state are treated at a health center, 1 in 10 in the country are treated at a community health center, 1,400 sites. We're estimating 25% of those health center sites to close potentially in the coming years. Many of them are in financial trouble. The tinkering of policy concerns me because we could lose some of our institutions. We have to be vigilant about that as well.
Well, thank you so much. That's a very good point. Thank you so much all for being here. I want to thank you, Michael Curry, CEO of Mass League of Community Health Centers and member of the NAACP National Board. I want to thank you, Nashira Baril, of the Neighborhood Birthing Center, and formerly with the City of Boston Health Commission, and of course you, Dr. Charles Anderson, President and CEO of the Dimock Center. It's been a wonderful discussion, and thank you so much for joining us here at GBH Amplifies. I am Ron Mitchell, your host from the Bay State Banner, and I want to thank you for joining us today.